I request everyone to be please seated. So I welcome all of you to Medicine Update 2022, respected Civil Surgeon ma'am and all the dignitaries present over here. This conference is a special conference to us, even though this is a third conference by Tricity Doctors Forum, but this is a special conference because this is a tribute to our very dear friend Dr. Sachin Pandav, who left us last year. Last year we were in a meeting when all of us, the team of Tricity Doctors Forum used to meet, and then Dr. Sachin Pandav said कि यार हमें बड़ा frequently मिलना चाहिए. And then I said कि sir conference करेंगे. And then who thought that after a month he'll leave us. And we were stunned by this event. But then we thought that his legacy must go on. The show must go on. And that's how the idea of this Medicine Update 2022 started. Dr. Sachin was a wonderful friend, but as a person, he was, for our conference, we used to call him eternal chairperson. जब भी कोई chairperson नहीं होता, I used to call, sir, chairperson नहीं है, आपको session chair करना है. And in our last conference, Insulinopedia, because there was a snowfall in Shimla and panelist has to rush in, and he became the panelist and answered all the tricky questions, and nobody realized that he is not the actual panelist, and such was the wisdom and knowledge of that person. And this year's conference, we got 200 registration, and such was the influence of this conference that I had to ask my team to literally stop the registrations. Whether this is aura of Dr. Sachin Pandav, or the pull of our esteemed faculty, or the guidance of our guides like Dr. Mokta and Dr. V.K. Mani. But this conference is a huge hit, as we can see from these numbers. We have worked very hard to bring the best faculty to you, and to bring the best topics, which the problems we face in our day-to-day OPD practice. And I am 100% sure that by the end of this evening, when you leave this conference era, you will become more wise and more knowledgeable. किसी भी कॉन्फ्रेंस की शोभा और उसकी इज्जत उसमें आए हुए फैकल्टी और डेलीगेट्स के कारण होती है. और मैं ट्राई सिटी डॉक्टर्स फोरम की तरफ से हाथ जोड़कर आप सभी को इस कॉन्फ्रेंस में आने और हमें इज्जत और इस कॉन्फ्रेंस को गरिमा प्रदान करने के लिए बहुत बहुत धन्यवाद देता हूं और आप सबका स्वागत करता हूं. थैंक यू.
To give tribute to Dr. Sachin Pandav, I would request Dr. Rashmi Pandav and Tricity Doctors Forum to come up on stage. For land typing, I request Dr. Adarsh Kaur, Civil Surgeon, Dr. Manjeet Singh, Head of ENT, Dr. S.S. Sodhi, Dr. J.K. Mokta, Dr. A.P. Savaria, Dr. Rashmi Pandav, and Dr. Manjeet Rehan. I request Dr. Sachin Verma to felicitate Civil Surgeon Dr. Adarsh Kaur and ma'am to say few lines.
गुड इवनिंग एवरीवन। ਅੱਜ ਮੈਂ ਡਾਕਟਰ ਸਚਿਨ ਪਾਂਡਵ ਦੀ ਨਿੱਘੀ ਯਾਦ ਨੂੰ ਸਮਰਪਿਤ ਇਸ ਕਾਨਫਰੰਸ ਵਿੱਚ, ਜੋ ਕਿ ਇੱਕ ਐਕੈਡੈਮਿਕ ਫੀਸਟ ਵੀ ਹੈ, ਆਉਣ 'ਤੇ ਬਹੁਤ ਮਾਣ ਮਹਿਸੂਸ ਕਰ ਰਹੀ ਹਾਂ। ਡਾਕਟਰ ਸਚਿਨ ਪਾਂਡਵ ਇੱਕ ਬਹੁਤ ਹੀ ਐਮੀਨੈਂਟ ਫਿਜ਼ੀਸ਼ੀਅਨ ਆਫ ਦਿਸ ਏਰੀਆ ਅਤੇ ਬਹੁਤ ਹੀ ਨਿੱਘੇ ਅਤੇ ਮਿਲਾਪੜੇ ਸੁਭਾਅ ਦੇ ਸੀ। ਹਮੇਸ਼ਾ ਹੀ ਉਹਨਾਂ ਦਾ ਹਸਮੁਖ ਚਿਹਰਾ ਸਾਡੇ ਅੱਗੇ ਆਉਂਦਾ ਰਹਿੰਦਾ ਹੈ ਅਤੇ ਮੈਂ ਪਰਸਨਲ ਤੌਰ 'ਤੇ ਵੀ ਉਹਨਾਂ ਦਾ ਲੋਸ ਫੀਲ ਕਰ ਰਹੀ ਹਾਂ। ਅਸੀਂ ਪਰਮਾਤਮਾ ਅੱਗੇ ਇਹੀ ਦੁਆ ਕਰਾਂਗੇ ਕਿ ਵਿਛੜੀ ਆਤਮਾ ਨੂੰ ਆਪਣੇ ਚਰਨਾਂ ਵਿੱਚ ਨਿਵਾਸ ਦੇਈ ਰੱਖੇ ਅਤੇ ਪਰਿਵਾਰ ਨੂੰ ਭਾਣਾ ਮੰਨਣ ਦਾ ਬਲ ਬਖਸ਼ੇ। ਭਾਵੇਂ ਕਿ ਉਹ ਬਹੁਤ ਹੀ ਛੋਟੀ ਉਮਰ ਵਿੱਚ ਸਾਡੇ ਤੋਂ ਵਿਛੜੇ ਹੈ, ਪਰ ਫਿਰ ਵੀ ਉਹ ਆਪਣਾ ਕਰਮ ਕਰਦੇ ਹੋਏ ਗਏ ਹੈ। ਇੱਕ ਡਾਕਟਰ ਦਾ ਕਰਮ ਹੈ ਮਰੀਜ਼ ਨੂੰ ਦੇਖਣਾ, ਹਮੇਸ਼ਾ ਤੋਂ ਅਸੀਂ ਸਾਰੀ ਉਮਰ ਇਹੀ ਕਰਦੇ ਰਹਿੰਦੇ ਹਾਂ। ਤਾਂ ਉਹ ਉਸ ਟਾਈਮ 'ਤੇ ਗਏ ਹੈ ਜਦੋਂ ਆਪਣਾ ਪੂਰਾ ਕਰਮ ਕਰ ਰਹੇ ਸੀ। ਤਾਂ ਇਹ ਵੀ ਇੱਕ ਮਾਣ ਵਾਲੀ ਹੀ ਗੱਲ ਹੈ ਪਰਿਵਾਰ ਵਾਸਤੇ ਕਿ ਉਹ ਆਪਣਾ ਕਰਮ ਕਰਦੇ ਹੋਏ ਗਏ ਹੈ। ਤਾਂ ਮੈਂ ਫਿਰ ਅੱਗੋਂ ਦੁਆ ਕਰਦੀ ਹਾਂ ਕਿ ਪਰਮਾਤਮਾ ਪਰਿਵਾਰ ਨੂੰ ਭਾਣਾ ਬੰਨਣ ਦਾ ਬਲ ਬਖਸ਼ੇ ਅਤੇ ਅਸੀਂ ਆਉਣ ਵਾਲੇ ਸਾਡੇ ਬਾਕੀ ਫਿਜ਼ੀਸ਼ੀਅਨ ਵੀ ਉਹਨਾਂ ਦੇ ਦੱਸੇ ਹੋਏ ਕਦਮਾਂ 'ਤੇ ਚੱਲਦੇ ਰਹਿਣ ਅਤੇ ਮਨੁੱਖਤਾ ਦੀ ਸੇਵਾ ਕਰਦੇ ਰਹਿਣ। ਥੈਂਕ ਯੂ ਜੀ।
I request Dr. Adarsh Kaur ma'am to facilitate Dr. Rashmi Pandav. There's one announcement for this car, Volkswagen 9966. This car is parked in front of gate. Can you please get it shifted or car keys be dropped? Thank you. To start with the first session, first talk, which is approach to subclinical thyroid dysfunction, I request our chairperson, Dr. Rajesh Chauhan, MD Internal Medicine, Indus Hospital, Dr. Vikas Bhutani, MBBS MD, Fortis Hospital, Dr. Manjeet Rehan, MBBS MD, Internal Medicine, Fortis Healthcare, Chandigarh. Speaker of this talk is Dr. Gagan Priya. I request chairpersons to address the speaker.
Hello. Good evening, friends. I welcome for the first talk of the evening Dr. Gagan Priya. She is MD, DM, Endocrinology from All India Institute of Medical Sciences. She is currently working as Senior Consultant Endocrinology, Fortis Hospital, Mohali. She's got multiple awards, Scope, IGEM Award for Best Reviewer, IGM Award for Best Review Article, and Fellowship Asia Pacific Pediatric Endocrine Society 2007. She is also editor of 3 books in endocrinology. She is section editor endocrinology, Urja, the Power of Her 2020, over 65 publications and 25 book chapters, founder, president, Flame, associate editor, Chronicles of Diabetes Research and Practice, co-editor, Diabetes India and Ambassador Diabetes, invited faculty at various national and international conferences. So it's our privilege to welcome Dr. Gagan Priya for this wonderful talk.
Good evening, everyone, and thank you so much to the esteemed chairpersons. Thanks to the organizing committee for even considering me for this, really humbling moment. I think Sachin is somebody we all really loved, and this is a little something I wrote in his memory. Sachin was my immediate junior in MBBS, and I've known him since 10th standard, so he's very close to all our hearts, Rashmi. So a smile that brought pure joy. I mean, I've never seen that smile in most people. A vision that saw endless beauty in flaws, so he could see beyond the flaws. A mind that was forever inquisitive, and I think Dr. Sachin Verma has already highlighted that. A nature that was completely disarming, a heart that cared with abundance, and a love that knew no bounds. I think that is what all Sachin meant to each one of us in this room, and we will forever remember him. So coming to the topic, what I'll discuss over the next 20-25 minutes is the approach to subclinical thyroid dysfunction. Now, we see a whole battery of thyroid function abnormalities in blood reports. So some of them are very easy to detect, pick up, and there's a clear path ahead of us. So you have suppressed TSH with elevated FT3, FT4. Straight away we think of thyrotoxicosis, evaluate its causes, and then we treat. The second could be an elevated TSH with low FT3, FT4. Straight away, overt hypothyroidism, no questions asked, evaluate and treat. We'll leave the abnormalities on the other side, but let's stick to these two abnormalities. When the free T3 and free T4 are normal, but the TSH is low or high outside the reference range. So are these cases true thyroid dysfunction, what we call as subclinical thyroid dysfunction, and how do we really evaluate? So what is subclinical thyroid dysfunction? It could be an elevated TSH with normal thyroid hormones, subclinical hypothyroidism, or it could be a suppressed TSH with normal thyroid hormones, subclinical hyperthyroidism. Now, why is TSH alone so important? Because there is a log inverse relationship between thyroid hormone levels and TSH. So for a person, even if there is a small dip in the thyroid hormone concentration, it will cause an exponential rise or fall in TSH. So that is why TSH is considered the most sensitive marker of thyroid dysfunction. And people who have an abnormal TSH may actually have either a mild thyroid failure or a mild thyroid hyperfunction, depending on TSH high or low. How do we define this normal range of TSH? So much of the data has come from what we call as the NANS third survey, the NAHN-NES survey, and over 15,000 healthy adult population, more than the above the age of 12 years were taken together. And what they looked at is what was the thyroid hormone levels for 95% of this population. And then they further kind of looked at very healthy population with no evidence of thyroid disease, no goiter, no thyroid antibodies, not on medications affecting thyroid. And they found that most of these patients had TSH within a very narrow range. So the range was somewhere from 0.4 to maybe 4.5. But how do you decide what is the upper limit? If you look at this curve very carefully, this is not a typical bell-shaped curve. So it's not, there is distinct skewing at the upper end. That means more patients tend to have a higher TSH, more people, not patients. And when they looked at 97.5th percentile, that fell somewhere around between 4.1 and 4.2. So based on this, the guidelines that were adopted by the American Thyroid Association in collaboration with ACE, they defined as the reference range is 0.3 to 4.5. But remember, 2.5% of normal people will still be above the 96th percentile. So it's 97.5th percentile, 2.5% are likely to be higher. And what is also to be understood that for this log linear relationship, each individual has a unique set point of thyroid hormones where the TSH would change. My set point might be different from somebody sitting in the audience, and therefore it's also important to look at secular trends of thyroid function over a period of time. What is the prevalence of thyroid dysfunction? Overt hypo and hyper are less common, so 0.3, 0.4%. But if you look at subclinical hypo, the data suggests that subclinical hypo may be present in 1 to almost 16% of population. And this is the data, the lower table is from Delhi, Dr. Marwa's group. They did an elaborate study on around 4,000 adults in Delhi and found that, if you look at males, subclinical hypothyroidism may be present in 15% and females 20%. And when they looked at hyper, it was less common. So let's talk of subclinical hypo first. What is subclinical hypo? Let's define the entity first of all. So TSH above the upper reference limit with normal FT4, but thyroid function has been stable for a period of time. It's not that the TSH is 8 today and it comes down to 4 today. That patient does not have subclinical hypo. We also need to establish that the HPT axis is normal. There is no intercurrent illness affecting the HPT axis. and there is no recent or ongoing severe illness. So that's when you can label subclinical. Now, of course, the argument goes, it's just a biochemical diagnosis. Many patients are asymptomatic. So why are we labeling a disease? But because of the log linear relationship, we do agree that some of these patients have true mild thyroid failure. So it's kind of in the latent stage wherein they may manifest overt failure over a period of time. There is high prevalence, especially in women, people with thyroid autoimmunity, more advanced stages, and iodine sufficiency. But TSH more than 4.5, 16% may have it. Are all of them equally sick? No. We can look at the gradations of TSH elevation. So when the TSH is between 4.5 to 10, that's one category in which 90% of people will fall as per studies, and 10% would have a TSH more than 10. So they cannot be put in the same basket together. Now let's look at a clinical scenario. A 41-year male with diabetes and hypertension diagnosed 2 years back on lifestyle modification comes with a TSH of 8.1, normal FT3, FT4, LDL is elevated, has had an episode of moderately severe COVID about a month and a half back. Dexamethasone was prescribed and he took it for 2 weeks. There is family history of hypothyroidism in the mother. He has overweight, grade 1 firm diffuse goiter. Can we make a categorical decision that this patient needs to be treated or not treated? At this point, do we have enough data? So what we have is an isolated raised TSH. We have to answer the question, is it really subclinical hypo? What is its clinical significance and will treatment help? So what are the causes that you can have an isolated elevated TSH with normal T3, T4? In recovery phase of sick euthyroid syndrome or recovery phase of any thyroiditis, TSH can rise above normal, but it would be transient. So that needs to be ruled out. Studies have also shown that people with obesity, class 2 or class 3 especially, they can have an elevated TSH. The mechanism being that leptin is increased and leptin increases TRH, which increases TSH. But there is no thyroid failure. So you cannot prescribe thyroxine for weight reduction in those patients. In old age also, studies are showing that TSH tends to rise a little above. Then there will be the true cases of subclinical hypo, which can be autoimmune Hashimoto's thyroiditis or because of all the other causes which can cause hypo. And then there can be some cases where there is an assay variability. Maybe the technician made a mistake. Or there can be assay interference from certain antibodies, heterophil antibodies. So one lab is giving you a high TSH, the other lab is giving you a normal TSH. Does not mean the first lab was wrong, but there was an interference in that assay. Then patients with impaired renal function also can have an elevated TSH. So let's look at this scenario. The patient, we have to rule out assay interference and transient forms. So we want to redo a TSH after 6 to 8 weeks, and we can add TPO antibody along with TSH to make sure we are ruling out autoimmunity. So let's say that there are two scenarios, different scenarios for this patient. In the first scenario, the TPO antibody was negative, repeat TSH came into normal range. The second scenario, TSH is 9.2, TPO antibody is 600. How do you explain scenario 1? Possibly there was sick euthyroid syndrome caused by COVID, which has now recovered. So again, totally different line of treatment, we don't treat that patient. Scenario 2, we definitely treat. So what are the concerns with true thyroid dysfunction, subclinical hypo? Will it progress to overt hypo? Are there adverse outcomes, cardio, metabolic, neurocognitive, related to pregnancy? And will the thyroxine actually help the patient? So will it progress? Studies have shown that almost 1/3 to half of the patients progress, but that also means that 1/3 to two-thirds don't progress. They remain either stable or evolve into normal course of time. So what factors predict progression? Anybody who has thyroid autoimmunity, TPO antibody positivity, or now we also have some studies with thyroglobulin antibodies, degree of TSH elevation. Higher the TSH, more than 10, more the likelihood of progression. Older age, women, patients with goiter are more likely to progress. Patients with risk factors, like anybody has undergone a radiation or radioiodine ablation in the past, or areas of high iodine intake, they are likely to have greater progression. The next question is it causing any symptoms? Because the symptoms of hypothyroidism, mind you, are very non-specific. All of these coarse, dry hair, fatigue can happen because of n number of reasons, and 70% of subclinical hypo patients are usually asymptomatic. In fact, very interesting data came from the Colorado thyroid disease study. They found that typical symptoms that we call off, coarse skin, cold intolerance, constipation, 4 or more symptoms were present only in 1/4 people with overt hypo, in 20% people with subclinical hypo, but they were also present in 17% of normal people. So really we can't attribute, but if you do have typical symptoms, a therapeutic trial can be offered in subclinical state, and if the benefits are seen, it can be continued. What about depression and psychological well-being? There are a lot of studies, most of them are small studies, non-randomized trials, or they are cohort studies. But what is the bottom line? Mood and cognition may improve when the TSH is above 10 and you put the patient on levothyroxine. For minor elevations of TSH, like 5, 6, 7, there may not be a benefit, but a therapeutic trial can be given in these patients also. So above 10, treat. Less than 10, you can give a therapeutic trial. What about cardiovascular risk? Because I think that's one big issue when it comes to subclinical hypo. There is a relationship with weight gain and visceral adiposity, with hypertension, with dyslipidemia. There is also greater prevalence of insulin resistance, and a relationship with type 2 diabetes is also elucidated, but that's relationship, not causation. Endothelial dysfunction, increased CMIT has also been documented. But does levothyroxine impact the risk? Does it impact weight or BMI? Studies have not shown that benefit. And in fact, we have to keep in mind that there might be a physiological rise in TSH in obesity, and weight loss, either through intensive lifestyle modification or bariatric surgery, in patients with borderline elevated TSH is found to normalize TSH. So offering them levothyroxine for weight loss is not going to give us any outcome. What about lipids? Studies have shown modest improvements in lipids, definitely, but the results have not been very consistent. So some studies have shown benefit, some have not shown benefit. Blood pressure, again, we don't have studies showing a clear benefit. Now, what about cardiovascular risk? CV event rate, CV mortality. Longitudinal studies suggest that those patients who have higher TSH, more than 10, and patients who are younger and have high CV risk, they do tend to have this association, but not the elderly. In fact, a large JAMA meta-analysis in 2010, in fact, was very path-breaking. What was seen was the extent of cardiovascular risk was proportional to the degree of TSH elevation, but it was not related to age or other risk factors. And a more recent meta-analysis of almost 5 lakh plus patients, data shows that there is modest association with cardiovascular disease and all-cause mortality, and mortality is particularly high in patients where inherent CV risk is high. And no association was again found in elderly. Contrast to risk of progression, here TPO antibody status does not determine the risk. So whatever the TPO antibody status, high the TSH, younger the patient, more the risk. And do studies show benefits? Will levothyroxine really reduce the risk? Yes, there are a number of cohort studies which have shown that in the younger people, when the CV risk is high, levothyroxine may reduce the risk. But there are 2 randomized controlled trials in elderly which have not shown that benefit. So actually speaking, there are no large-scale randomized controlled trials to show that, levothyroxine reduces the risk, but it may improve some risk markers, and cohort studies suggest potential of benefit for younger patients and for patients with high CV risk, but not for elderly population. In the elderly, like I said, with age, the TSH tends to rise. In fact, the NANS data itself showed that for the 20 to 30-year age group, the 97th percentile was at 3.56, but for octogenarians, by 70 it had increased, by 80 it had increased to 7.49. So a 7 or 8 TSH in an old person might actually still be normal. We have to weigh the benefits of treatment. And some studies, very interestingly, have linked that higher TSH, borderline high TSH actually is associated with better survival and longevity. In fact, when you try to lower it, you might actually be hurting that patient. And the risk of overtreatment is also more. What about children? In children, you can have borderline TSH. If it is autoimmune or if there is goiter or other autoimmune diseases, there is definitely a risk of progression, but just an isolated elevated TSH may not be causing any harm. It has no effect on skeletal growth, neurodevelopmental outcomes or pubertal outcomes. And treatment again is based on degree of TSH elevation and if they have antibodies or other concomitant diseases. One small word about pregnancy. I think pregnancy is an altogether different ballgame when it comes to thyroid. So subclinical hypo has been linked to a number of adverse perinatal and maternal outcomes like miscarriage or preterm delivery, and also even with gestational diabetes, low birth weight. Trials have shown that levothyroxine will reduce miscarriage rate and premature delivery. That evidence remains, but the other outcomes have not shown change. So this was what we wrote for the ITS textbook, that when a woman is planning pregnancy or has pregnancy, you start looking at risk factors. Is there a family history or a personal history of thyroid dysfunction in the past? Is there symptoms of goiter or thyroid dysfunction? Is this a high-risk pregnancy? There's infertility in the background, or a woman is undergoing IVF or ICSI, or there is a history of recurrent miscarriages. In that case, if the TSH is above the upper limit of normal, treat everybody, whether or not free T4 is normal or not. But if TSH is between 2.5 to 4, you look at antibody status. If antibody is positive, you treat. If negative, you can follow up. For TSH below 2.5, we don't have sufficient data for treatment. Then the question is, why not treat everybody with a borderline elevated or a TSH of 7 or 8? Why not treat all? Because one, you're putting a lifelong disease label, lifelong medications, testing, clinic visits, everything is adding on, and we don't know of benefits in a substantial proportion of these populations. Some of them may actually be transient, so don't jumpstart to start treatment on day one. Also, there is a very narrow therapeutic range of that normalcy. So in one study, almost 1/4 of patients at one point of time were being overtreated, TSH was suppressed. And if you look at your clinic data also, you will identify that many times the patients are actually getting suppressed, and for 1 to 2 years, they don't come to you in that state. And slightly elevated TSH in the elderly actually gives better longevity, so why treat that? Now, what factors will favor levothyroxine? TSH, which is clearly high, more than 8 or 10, if it is progressively rising, if there is goiter or positive antithyroid antibodies, if a woman is planning pregnancy or has pregnancy, or there is history of infertility, in childhood you could treat if there is goiter, autoimmunity, other diseases like, let's say, type 1 diabetes, and if there is high CV risk or established cardiovascular disease, especially if it's a younger population. You can give a therapeutic trial in patients with depression or bipolar disease or frank symptoms to see if they improve. Let's look at 2-3 case scenarios, and then we'll briefly talk of subclinical hyper. So an 85-year male with hypertension, diabetes, controlled on metformin and amlodipine, TSH is 7.5. Do I treat? 85, 7.5, nothing else. We can leave this patient, monitor maybe another 8 to 12 weeks down the line. A 30-year lady was diagnosed with type 1 diabetes, and now in an annual screening, you see TSH last year was 4.1, now it is 6.5. She has a grade 1 firm diffuse goiter and her antibody is positive. we treat this patient. Another lady, 55 years, diabetes, controlled hypertension. She has vague symptoms of fatigue. Her TSH is 8.9 and her total and LDL cholesterol are elevated. This is a relatively young patient with high CV risk. Treatment might offer benefit, so we can consider. Very quickly, in 2-3 minutes, let's talk of the other end of the spectrum. We'll start with a case scenario. A 63-year lady has menopause 10 years back. She has hypertension, type 2 diabetes for the last 10 years and has had stable control. Now she has had weight loss and fatigue. You look at her thyroid profile, T3, T4 are at the upper end of the normal, TSH is suppressed, 0.1. And she has mild tachycardia, BP, mild tremors also. And on examination, she also has a right palpable thyroid nodule. What do we do? What does she have, first of all? Clinically, she looks like she has subclinical hyperthyroidism, not just a lab abnormality, but we would want to still think of what other causes can cause a low TSH with normal free T3, free T4. So subclinical hyper is one cause, but a patient with transient thyroiditis and the thyrotoxic phase can also come with this. A patient taking levothyroxine may be oversuppressed. So if somebody is not telling you that history, you have to elucidate, are you on thyroid medication? Fictitious ingestion of thyroid hormones. In fact, I had this interesting lady, she was taking 4 pills of thyroxine and not telling anybody. She took it for weight loss. But that's the history. If you don't elicit it, you are lost. You will end up prescribing, anti-thyroid drugs. Recent history for hyperthyroidism, drugs like glucocorticoids and dopamine can also cause a central TSH suppression. And also early phases of non-thyroidal illness, you could have a suppressed TSH. So what you need to do is establish persistent lab abnormality and what clue can you take from the lab findings. In all of these other cases, like non-thyroidal illness or drug-induced suppression, free T4 and free T3 would be towards the lower end of normal. But in subclinical hyper, they will be towards the higher end of normal. So that is one thing you can look at. How do we grade subclinical hyper? Grade 1 when TSH is clearly low, less than 0.1. That's suppressed TSH. Grade 2 is when the TSH is in the just below the reference range, 0.1 to 0.4. And the prevalence, if you can see, again, it's not a very common abnormality. The causes can be all. Now, what are the risks? Progression to overt toxicosis and cardiovascular health and bone health concerns. And we also have to, again, answer the same question. Clinical course will depend on the underlying disease. If it's toxic adenoma or toxic multinodular goiter, it's not going to go into remission. It will maybe stay the same or progress over years. So that has to be taken into consideration. If it's transient thyroiditis, in its natural history, it's going to resolve. So again, you want to see that progression. Graves' disease, it may resolve, it may progress. I think there are no real predictors of which way it will go. People with larger gland, greater degree of FT4, they are not likely to resolve. And the rate of progression is more the TSH suppression. So what are the concerns? There are studies that have shown that there is not clear effect on cognition or quality of life, but studies have clearly shown an increased risk of atrial fibrillation and heart failure, especially when TSH is less than 0.1 or TSH is in that 0.1 to 0.4 category, but patient has other risk factors for cardiovascular disease. Same consideration applies to bone fractures. People with TSH below 0.1, grade 2, are more likely to have a worsening of bone health if the hyperthyroid state persists. And post-menopausal women, even the fracture risk has been shown to be improved, shown to increase, and treatment might actually benefit these patients. Do we have randomized trials to say it will definitely benefit the patient? That's not really there. But I think good clinical sense would give us the judgment that it is. So what does the ATA guidelines say about treating these patients? Below 0.1, treat all elderly individuals. For younger individuals, consider treating them. So evaluate the cause and treat. And especially younger individuals, when they have heart disease, they have toxic symptoms, they have osteoporosis, or it's a post-menopausal woman, you would want to consider, you want to treat those individuals. For TSH between 0.1 to 0.4, an asymptomatic individual less than 65, you can leave them and just observe them. But for elderly and those with these risk factors, you would still want to consider treatment. It's not an absolute indication, but you can err on the side of evaluation and treatment. So how do we evaluate? Evaluate for the cause of the hyperthyroid state, or if it's thyroiditis, you would get. You can offer for toxic adenoma, you can go for radioiodine ablation. For toxic multinodular goiter, all the options are on the table, whether it's medication, radioiodine, or surgery. And for Graves' disease, a low-dose antithyroidal drug usually tends to work. For patients who are not good surgical candidates also, you can offer low-dose antithyroidal drugs over a long period of time. So our index patient, had a toxic adenoma and a radioiodine ablation cured her in one sitting. So very quickly, winding up, 3 case scenarios. A 39-year lady, TSH is 0.3, FT3, FT4 normal. There's no goiter, no family history, no significant medical history. What do you want to do for this patient? Just follow up maybe another 6 to 8 weeks and let's see the TFT again. 49-year lady, TSH is 0.2, FT4 is normal, FT3 is elevated, grade 1 firm diffuse goiter. First question, this is not subclinical. This is clinical thyrotoxicosis. In iodine deficiency, T3 elevation may be there and T4 may still be normal. So it's T3 toxicosis. She had TRAB positive. She was treated as Graves. 63-year male has CAD, underwent PTCA 5 years back. There is LV dysfunction. He presents with AF fast ventricular rate, FT3/4 normal, TSH 0.3, and on examination you find a multinodular gland. This patient merits further evaluation and treatment. So key takeaways, abnormal TSH is a common anomaly in lab reports. So what you want to understand is it persistent? Is it really true thyroid dysfunction? For subclinical hypo, the considerations for treatment would be a TSH clearly above 10 or a TSH which is lower but has positive antibodies, goiter or other risk factors. And you would consider the cardiovascular risk also, as well as consider whether or not this is a woman of reproductive age group wanting a pregnancy or is pregnant. For subclinical hyper, you want to look at the risk of atrial fibrillation, heart failure, osteoporosis. So elderly people would merit treatment. Younger people with these risk factors would also merit treatment. So I think I'll conclude here with this statement. Medicine is definitely a science of uncertainty and an art of probability. I think we all keep learning every year, every conference, we add more to our knowledge. Thank you so much, and I hand back to the chairs.
So excellent coverage of a topic, and every evening it appears that we are learning for the first time. So thank you very much for excellent coverage. And a question or two from the audience we can have, I think. Any question from the audience?
Dr. Gagan Priya, right? We are getting so many cases in the routine outdoor or even from the pre-anesthetic checkups.
Yes.
Like they get the normal thyroid functions and TSH is slightly elevated around between 5 to 10.
Yeah.
TPO not done. And they normally do, most of the time they would do T3 or T4, which is total. They would not ask for FT3 or FT4. And most of the labs, if you see, or most of the reports we are seeing, they are doing the total one.
Yeah.
So one anomaly is that because you have to
okay.
ask for another investigation. And how to go about these patients, because you get so many calls, like
True,
between
I
5 to 10,
completely agree.
and normal T3 or normal, but just TSH between 5 to 10. So how do you advise on these?
Yeah, I think again the same thing. One, for perioperative issues, a subclinical hypo really would not create a huge risk. So perioperatively, I think it's fine. If it's possible to do a full thyroid panel, it would be excellent before giving the clearance, because, like I said, there's a unique set point for each individual. A person with a TSH of 10 may actually have a low free T4, and I think you've also experienced it in reports. But another person with a TSH of 14 may also have normal free T4. So I think ordering a full panel would be good. But clinical indicators, I mean, are there hypothyroid symptoms? What is the heart rate? We can also look at the reflexes. I mean, if there's significant tissue hypothyroxemia, you would encounter bradycardia or mixed edematous kind of features, and the ankle jerk might have a delayed relaxation. So I think for perioperative, I mean, you already doing most of that.
That's okay, but
Yeah.
I just want to
Yeah.
know for the audience sake also, between TSH of 5 to 10 and TPO antibody positive,
Positive.
would you treat it?
Yeah, I think in those cases, we could err on the side of treatment. Again, that's a relative indication. If it's a young patient, I would definitely want to, because the risk of progression becomes a little higher. But if it's an elderly individual, I mean, already the patient is 70 plus and having a TSH of 7 TPO antibody, we can also sequentially follow those patients.
And then there are scenarios like TSH more than 10, anti-TPO negative.
Negative, yes.
In those scenarios.
Yeah. So
Would
in
you
those
want to
scenarios,
treat or
I
just
think,
therapeutic trials?
yeah, most studies are actually showing that there can be symptoms, there is elevated CV risk, and CV risk does not depend on TPO antibody status. So it does not depend on the thyroid autoimmunity, it depends on the degree of thyroid dysfunction. So in those cases, I think if they are high CV risk, definitely consider treatment.
Thank
Yeah, thank you.
I think
Yes, I think, thank you so much, Dr. Rajesh. That's an important question. Sometimes, thyroid TPO antibody you may not find positive. We've had quite a few patients where TPO was negative, but thyroglobulin was positive. And let's say that is also negative, do palpate the gland. If you find a firm diffuse gland, you can look at ultrasound. A heterogeneous kind of a pattern, there's a typical pattern of Hashimoto's thyroiditis that you can get on ultrasound. Sometimes when you still cannot diagnose, maybe even an FNSE can be offered to look for chronic lymphocytic thyroiditis, but those would be very few select cases. Thank you.
Okay. I think if there are no more questions, I will thank Dr. Gaganpriya for this excellent talk.
I request the chairpersons to present memento to Dr. Gagan Priya. I request Dr. D.K. Oberoi to present the mementos to the chairpersons. Dr. B.S. Bhatia. Dr. Rajesh Chauhan. Dr. Vikas Bhutani. Dr. Manjeet Rehan. Dr. Rajesh Chauhan. Going ahead with next talk, approach to diastolic heart failure, I request the chairpersons, Dr. Amit Gupta, MBBS, MD, DM Cardiology, Alive Health and Diagnostic Center, Dr. Ankur Ahuja, MBBS, MD, DM Cardiology, Fortis Hospital, Mohali, Dr. I request the speaker, Dr. S.S. Sodhi, and request chairpersons to address the speaker.
We are fortunate to welcome Dr. Sodhi for the lecture. He is an eminent non-invasive cardiologist of Tricity, and we are looking forward to his lecture. Welcome, Dr. Sodhi.
Good evening, everybody. And I congratulate the organizers for this wonderful academic feast, and also appreciate the tribute to Dr. Pando, a great human being and a good friend of mine also. I think he was friendly with everybody in any case. So today the topic is diastolic heart failure. Systolic heart failure is very easy to treat. We have been treating since many years. There's nothing new about it. Actually, a lot of trials have been done in heart failure as such, and a lot of beneficial drugs have been found. But it was always noticed that a subset of heart failure actually never responded to whatever treatment you gave. So this concept came up of diastolic heart failure. And the importance is that here the prevention is much more important as compared to the cure, as compared to the treatment. This is, I think everybody knows that it's a clinical syndrome characterized by typical symptoms, signs, and biomarkers due to functional or structural cardiac abnormality, wherein the tissue needs cannot be met except at an elevated filling pressure. So basically, elevated filling pressure is one of the signs of heart failure that in general. And this study actually was done on heart failure. And this was the study which showed that a subset of heart failure patients, especially those with ejection fraction of more than 50%, but with all the signs and symptoms of heart failure, they did not benefit from the treatment that was given for other patients of heart failure. They did not benefit means that the primary endpoints were cardiovascular death or hospitalization. So these were not fulfilled by the drugs. So then it led to the classification of heart failure as to what are the different subsets. So we have heart failure with reduced ejection fraction, heart failure with mid-range, or you can call it mildly reduced ejection fraction, heart failure with preserved ejection fraction, and heart failure with improved ejection fraction. So these were the subsets that were there. And how do we define them? Reduced ejection fraction is simple, 40 or less than 40% of LVEF on echo. Mid-range is between 41 to 49%. And preserved ejection fraction is 50% or more. So that is all symptomatic cases. And improved means that patients with symptomatic heart failure with a baseline LVEF of less than equal to 40%, and more than equal to 10-point increase from the baseline LVEF. So say 34% becomes 40%, so he becomes an improved EF. And a second measurement of more than 40%. So a 30% becomes 40 or more, it becomes an improved, although he is a heart failure, he is still an improved heart failure at least. Now, the difference between a systolic heart failure and a diastolic heart failure. So basically when you have reduced ejection fraction, generally the heart size is increased. The contractility, of course, is decreased. On the other hand, when you have preserved ejection fraction, the contractility is normal. It is the filling pressures which are high, and it is the relaxation which is impaired. So as you can see, the heart may generally be hypertrophy and other causes as we'll see in future. So the definition of preserved ejection fraction heart failure is basically with ejection fraction of 50% or more. So generally you will be having left ventricular hypertrophy. Left ventricular diastolic dysfunction is a very important sign of this and can be assessed from echo. Increased LV mass. So basic issue is the stiffness of the heart with impaired filling. The pumping is okay, the function otherwise is okay. The filling is impaired due to stiffness, which can be caused by hypertrophy due to various causes and can lead to the symptom. The symptoms, signs, symptoms of heart failure will generally be the same practically, in the sense that the patient would have dyspnea, patient would have fatigue, patient can also have pedal edema, signs of congestion and pulmonary rales, etc., etc. So when, as per the AHA-ACC guidelines, when the patient has symptoms of heart failure and the ejection fraction is equal to more than 50%, it is basically a heart failure, which preserved ejection fraction. And the ESC guidelines, that is European Society guidelines, they say they are a little more strict. So the signs of heart failure should be there, and ejection fraction 50% or more. Then elevated levels of natriuretic peptides, NP, anti-pro-BNP, and documentation of LVH, left atrial enlargement or diastolic dysfunction. The natriuretic peptides are useful both, one for diagnosing the congestive failure, because if we want to differentiate cardiac cause of congestive failure vis-a-vis other diseases which mimic the same, then we have to see these values, and if the values are beyond normal, higher than normal, it suggests that the cause is cardiac. That is one. Secondly, the levels also will give some idea, though not correlating very well, but they do give some idea as to the prognosis and as to the severity of the disease. So more the values, the chances are that the heart is more unstable. And in the trials, an average of 300 in sinus rhythm and 900 in atrial fibrillation have been used. Atrial fibrillation is a very bad happening in a patient of cardiac failure, whether preserved or non-preserved, because once you have atrial fibrillation, the atrial kick is lost and the patient worsens immediately and greatly. So what was found was, and this is surprising, that more than 50% of patients who were diagnosed as heart failure, almost 50 or more, they turned out to be patients with preserved ejection fraction. So we have patients who have dyspnea on exertion, fatigue, and symptoms of heart failure, but the EF is normal. So that does not mean that this patient is not in heart failure. He is in heart failure, and he has an equally bad prognosis as a patient with a heart failure. So 40% or 50%, once you have heart failure, you are going to have a bad prognosis. And with the growing population and the comorbidities, so incidence of heart failure with preserved ejection fraction is growing. As we have more and more aging population, more cases of hypertension, more cases of diabetes mellitus, the incidence of this entity is going to increase. So as you can see, 4.9% prevalence in the age of more than 60 years. And this population is about 63 million or more, increasing every year. So future prediction is practically 1 in 5 elderly patients will be developing heart failure. So you can see the magnitude of the disease that we are going to face. Indian data is not is scarce compared to the foreign data. So a lot of things are extrapolated according to the data from US, etc. But we have a registry, the National Heart Failure Registry, Trivandrum Heart Failure Registry. But in this, they showed the incidence of preserved ejection fraction heart failure was around 25.8%, not 50% as in the Western countries. Then we have an ADIR registry where it was around 50%. So generally, you can say between 40 to 50% we have. Now, the worrisome thing is that the in-hospital mortality and the 3 years mortality, this was lesser in heart failure with ejection fraction which was preserved. So a preserved ejection fraction is definitely better than a reduced ejection fraction, but it also has a bad prognosis. We of course need to rule out mitral or aortic valve disease, congenital heart disease, constrictive pericarditis, endomyocardial fibrosis, rhythm abnormalities, amyloidosis. Amyloidosis is very important. Cardiac MRI will help us differentiate because they may present as a hypertrophied heart, they may present as a typical case of preserved ejection fraction heart failure. But early diagnosis and treatment of this would be helpful. Then we have HOCM, which will be generally obvious on echo, idiopathic restrictive cardiomyopathy, etc. So contributory factors may be many. Multiple cardiac, vascular, non-cardiac abnormalities like kidney disease, pulmonary hypertension, impaired LV diastolic systolic function, myocardial ischemia, infarction, left atrial abnormality, aging, as I said, anemia, obesity. So all these contributory factors have to be looked into. So as I said earlier, we have a variety of contributory factors. We have autonomic dysfunction, COPDs, iron deficiency anemia. So as you can see from this chart, there are many of them. And these are the common conditions that we encounter in our daily practice. So these need to be taken care of because they may look innocuous, but ultimately they can lead to a heart failure and a bad prognosis. Then we have a scoring system of H2F, preserved ejection fraction score, or heart failure association preserved ejection fraction score. This is one of the scores, H2P FPEF score, which is commonly used. So as is obvious, the higher the score, the more the chances of it being a heart failure with preserved ejection fraction, and the worse the prognosis. So as I said earlier, these are the risk factors. These are the common ones listed, and if we can prevent them or we can reduce their intensity, we are likely to reduce the severity or the incidence of heart failure. Is elderly age, more than 70 or in men or 60 in women. Metabolic syndrome, diabetes, which is very common in India. We have overweight, obesity, again very common. Physical inactivity, arterial hypertension, fibrillation, ECG abnormalities, rhythm abnormalities, and elevated levels of BNP and anti-pro-BNP. Now comes the main problem, that the routine drugs which have been shown to be beneficial in heart failure with reduced ejection fraction may not be useful here. So this is the major problem. So prevention is better than cure. We can only give symptomatic treatment in most of the cases. A new drug has come up which I will be discussing, but the question is that most of the drugs that we have been used to, like ACE inhibitors, ARNI, or beta blockers, they or diuretics like mineralocorticoid receptor antagonists like spironolactone, they are all without much of help in this condition. Diuretics can be helpful, like loop diuretics, etc., but that is basically for symptom alleviation and quality of life. The incidence of hospitalization or the cardiac death, that is not prevented by these drugs. So these are the pillars of heart failure therapy. You know, you talk about heart failure therapy and we would like to put our patient on all of them. But the first three are absolutely of no benefit. Unless there is a cause which is, like for example, somebody's arrhythmia and then you give beta blocker, it's a different issue. But for the heart failure per se, they are not important, not useful. The SGLT2 inhibitors, which came for diabetes, now have been found to be actually useful in heart disease. And for heart failure, they are one of the pillars of therapy. Patient has diabetes, patient does not have diabetes, it does not matter. We have to give these to all the patients of heart failure that we are treating, unless there is a contraindication or a problem with that. So I won't go into details of all these trials. There are many trials that have been done, but most of these trials came up with the opinion that there is no treatment for this condition, preserved heart failure, ejection fraction condition. The Paragon heart failure trial actually, in fact, even put ARNI, out of the list of treatment. ARNI was we thought that ARNI will be able to treat the preserved heart failure also, as it is very effective in reduced heart failure. Unfortunately, that did not happen. So what is important? When you can't treat, as such prevention is important, but what you cannot treat, prevention is more important. Like we always tell our patients that, wear full sleeves clothes and all during this season of dengue, because what you can't treat, prevention is the most important and the only way out. So these are the, simple 7, which simple 7 basically, they are the most common associated factors, relatively easy to prevent or treat. So smoking cessation, obesity reduction, exercise, diet, blood pressure control, cholesterol reduction, glucose control. So all these things are generally being done by us. We should be a little more specific, we should be more aggressive, and we should treat this if we want to prevent a heart failure. These are the comorbidities very commonly associated with heart failure with preserved ejection fraction. Smoking, as you all know, we always tell all the patients to stop smoking. Even 1 cigarette per day is harmful. And infarction is increased 6-fold in women and 3-fold in men smoking 20 or more cigarettes per day. So 49% higher risk of heart failure. Independent risk factor for heart failure, MI and death. And cessation leads to a reduction in mortality and morbidity within 2 years, up to a magnitude similar to pharmacological therapy. So you don't treat the patient and he just stops smoking cigarette, within 2 years he gets the same benefit. And normally by 5 to 10 years he practically becomes as normal risk as another person who has never smoked. Smoking also is passive smoking. So we should tell the patient that not only is he harming himself, he is harming his family also. Because 50% of the risk goes to the people who do passive smoking. So mostly family members. Then obesity. See, basically any condition which is pro-inflammatory, which increases the sugar levels, or which, these are all causative factors for atherosclerosis. So patient has more chances of having ischemia. So obesity is a pro-inflammatory condition. Symptoms of obesity are similar to heart failure. Patient will have fatigue, patient will have dyspnea. So we have to be careful as to distinguish between the two. And I said, if you are doubting heart failure, you can always do a anti-pro-BNP and find out whether it is raised or not. Then obesity can lead to obstructive sleep apnea. This I think is very common. Lot of patients are there whom we probably forget or we overlook this. But I think if we order a sleep study, we will find a lot of patients actually having obstructive sleep apnea. And you treat that and patient becomes fine, his BP comes down, things get much, much better. So weight loss with diet or bariatric surgery has been shown to be beneficial. Exercise, I don't think we need to say much. Your exercise, everybody knows, is important. And the only thing I would now suggest is that don't overexert also. I think too much of exercise, too much of bodybuilding. Bodybuilding I am absolutely against, to be very honest. I tell my patients very clearly, don't go for your muscles of the arms, go for the muscles of the heart. So if you try to do a lot of muscle building and all, you are likely to anyway end up with hypertension later on in age. So it is better to go for cardio exercises up to a certain level, limit as per your age. Overexerting, as we can see, has led to a lot of issues. Above 40, I advise all my patients, for whatever, whether they have hypertension or anything, that go for a TMT first and then start your cardio. So it appears to improve the pathological pathways which lead to heart failure, for example, diabetes, hypertension, obesity. So all these things will be, either cured or improved with the exercise, and this will benefit. Diet, as we all know, a low sodium diet, low calorie diet, and DASH diet. DASH diet basically is low in sodium and rich in potassium, magnesium, etc. So this diet is proven to be of help. And obvious that we should manage the blood pressure, because the blood pressure will lead to LV hypertrophy. This can lead to diastolic dysfunction by impaired filling. And the SPRING trial, which had a very strict criteria for BP control, it showed that optimal BP, that is around 120 millimeters systolic, was associated with 38% reduction in risk of heart failure and 27% risk reduction in all-cause mortality, compared to the arm with BP of about 136 millimeter mercury systolic. Actually, any BP above 120, so basically it's a pre-hypertensive patient. Generally, it is better to be below 120, but if it is above 120, then the risk starts increasing with the increasing level of the blood pressure. Of course, we start treatment only after 130, and if other factors are there, but better try to keep it below 120 with the help of salt restriction and exercise. Cholesterol, obviously, atherosclerosis will be there, and this will lead to ischemia and again damage to the muscle and therefore stiffness of the muscle. Paradoxically, it has been shown that it does not have much effect in patients with reduced ejection fraction, but control of cholesterol is surely beneficial in heart failure with preserved ejection fraction. A chart 2 project is going on for further assessment. Diabetes, diabetic cardiomyopathy is a well-known entity. So diabetes one should control. If you can prevent, it's even better. India is becoming diabetic capital, hypertensive capital. So ultimately, imagine the number of heart failures that we are going to have in future. And metformin, just as I mentioned, it is safe in patients of heart failure. Now, SGLT2 inhibitors, empagliflozin, dapagliflozin, these two drugs have come up as a treatment for diabetes and luckily have been found to be very, very effective in heart failure. Now this trial, this is an important trial because this established empagliflozin as a treatment for all patients of heart failure irrespective of their diabetic status. It has benefited both diabetics and non-diabetics also. And luckily it has also shown some effect in patients with preserved ejection fraction. So this is the only drug which is relatively useful for reducing the hospital admissions and the death in patients of heart failure with preserved ejection fraction. Now, in the Paragon heart failure trial, well, it was a bit controversial, things were there. It generally showed that no benefit was there with ARNI in patients of heart failure with preserved ejection fraction, but there was a subset of women and patients with an ejection fraction between 50 to 57%, which showed benefit. So this trial has basically kept ARNI still in one of the armamentariums that you can use it if nothing else is available. So it has not totally put it out of vogue for this condition, but the effect is little less, relatively not very well documented. More trials are required. Now this is the worst part. The prognosis is that 50% of the patients will die in the next 5 years, practically irrespective of whatever you do. So therefore, this is a very high mortality rate. 50% in 5 years is a very, very high mortality rate. And before that, he will be incapacitated for a year or two. So you can imagine the drastic effect this has. So this makes it all the more important that we prevent this at all costs. So this was about the heart failure. Thank you.
Thank you, Dr. Sori, for a very nice and elaborate coverage of heart failure preserved here. Just a comment. So it's when the substrate is there, symptoms are there, and you have echo findings as well as BNP markers are there. It's generally easy to diagnose heart failure preserved here. But often we face a dilemma when we see a patient who has a substrate, who was asymptomatic till now. Now he has comorbids, fluid overload because of something else. Now you have elevated markers also. So how do you go about it? Maybe it's a cor pulmonale or AKI and AF. So just a comment on that. How would you go ahead with that kind of scenario?
Yeah, so that is the issue because a lot of things will be overlapping in both of them. So in this condition, anyway, diuretics and all we are going to give, whether it is a cor pulmonale or anything. And that will be a symptomatic relief for the patient also, number one. Number two, then we have these markers, the natriuretic peptides and all. So we can use that also as one of the helping indicators for whether it's a patient with heart failure or not. Diastolic dysfunction, but that will be there in probably other conditions also. But if we demonstrated diastolic dysfunction, clear cut, and we demonstrate the high natripeptide peptides, then chances of patient having a heart failure are definitely more. If we suspect other conditions also like cor pulmonale, then we should treat those conditions that will help in this patient. Because that is, as such, one of the causes of heart failure. And AKI also, they also lead to heart failure ultimately. So,
Thank you so much.
thank you.
From my relative doing in America. So the diastolic or systolic you are saying, and simple 7 I could understand. It's very, very important things you have mentioned. Another this obesity. In obesity treatment for OSA. What do you prefer here? This is a CPAP or uvulo-palatopharyngoplasty as a continued positive airway pressure. What are your experiences?
So actually that will depend on whether it's an obstructive variety or a central variety. So if it's an obstructive variety of sleep apnea, then we can go for the surgical procedures. And if it's a central, then we go for a CPAP.
So like now when the palate, soft palate moves up and down. And so like one of my relative came from America and he was having so much snoring in the room and I was worried that Jija ji nu kuch ho hi na jave. But next time he brought with him a family that is CPAP machine. He applied and moisturized air is going and 7 hours he slept very nicely. And it's very, very effective, I think, yes. CPAP. And uvulo-palatopharyngoplasty is like if there are adenoid and large.
Yeah, exactly, obstructive variety.
Obstructive.
This is a neurogenic central variety which you are talking.
Thank you. It's a wonderful talk, really.
So, thank you. One thing I would like to mention about obstructive sleep apnea, I said earlier also, it's very, very important. And it's a lot of time we have missed that. And if you treat that, it definitely gives a huge benefit to the patient. His quality of life improves drastically. And if you don't treat, he can have arrhythmias and he can have a sudden death also due to this.
Sir, a very interesting talk, sir. So just want to clarify, what is the filling pressure of the left side when you say it's a diastolic heart failure for the left side and for the right side?
So both the sides have a different pressure. The left side we have around 25 millimeters. And generally, sir, what we have is we go by tissue Doppler and we do a ejection, E by E dash on tissue Doppler on echo. So that generally gives us an idea about this, because otherwise we can always go for invasive methods also. But generally this is a very simple way of doing it.
So 25 millimeters mercury on the left atrial pressure at diastolic and diastolic. Any comments, sir, from three of you, sir?
Between 50 to 20.
So very high pressure, sir, 25 mm on the left side. It will result in overt LVF, I suppose.
Yes, absolutely.
Absolutely. And sir, any criteria of the thickness of the LV wall in hypertrophy when you classify it as a?
So generally more than 1.5 millimeter, 1.1 millimeter we classify it as a hypertrophy.
Dr. Manish, let me answer. There is some specific criteria which is making highly probability of a diastolic heart failure is enlargement of the LA. The size of LA should be more than the left ventricular size with associated mild pulmonary artery hypertension where pulmonary artery pressure is more than 40. This is basically the criteria which we commonly use is for the diagnosis of diastolic heart failure. Diastolic heart failure. There are so many other causes of pulmonary artery hypertension and LA enlargement there, but with the sign and symptoms suggestive of heart failure with the elevated biomarkers with this particular set of, as Dr. Sodhi said, E by E prime ratio plus LA enlargement more than LV and mild pulmonary hypertension, it is highly suggestive of this diastolic heart failure. Otherwise, diagnosis is highly difficult.
Very nice talk, Dr. Sodhi. And I feel we personally find many patients having hypertension, renal failure, and it becomes very, very difficult sometimes to label it. Is it a fluid overload, or is it a diastolic heart failure, or is it both at the same time? So, in your experience, sir, about like BNP doing in these patients, BNP is elevated. So, how do you classify? Is there anything that you take in practice when you manage renal failure patients with heart failure as well?
See, there are two things. One is that the elevated enzymes generally suggest is more towards the heart failure, relatively more towards the heart failure. Second is, as I said, by and large, the initial treatment is going to be diuretics, especially in the due to the congestion. So that also is one of the helpful things. And then again, diastolic dysfunction of the heart, LA enlargement, LV hypertrophy, LV mass is increased or not. Although kidney disease can lead to hypertension, which can lead to increased mass, but then that is the one of the mechanisms of heart failure also. So by and large, I would prefer to do the markers, the natriuretic peptides, as well as give the patient diuretics, because the symptomatic treatment for heart failure is anyway diuretics, even for preserved heart failure, for improving the quality of life. And then the patient is also simultaneously being given dialysis or whatever is required. And if there is a fluid overload, dialysis can help in that case. And then we can again determine what is happening, what are the values, etc. So thank you. Oh, sorry.
Thank you, sir. I request the chairpersons to present mementos to Dr. S.S. Sodhi. I request Dr. B.K. Dhiman to present mementos to the chairpersons. I request Dr. Sachin to present the mementos to the chairpersons. Dr. Amit Gupta, Dr. Amit Soni, Dr. Ankur Ahuja. Thank you. Going ahead with the next talk, common errors in management of type 2 diabetes mellitus, I would request the chairpersons on stage, Dr. Rajat Gupta, MBBS MD DM Endocrinology from Alchemist, Dr. Sachin Mittal, MBBS MD DM and Endocrinology from Fortis, and Dr. Dinesh Garg, MBBS MD Internal Medicine from Sector 16. The speaker of this talk is Dr. Anil Bhansali. I request the chairpersons to address the speakers. Thank you.
Good evening, everyone. At the outset, I would like to congratulate the organizers for the wonderful event and also, appreciate the heart-touching gesture as a tribute to Dr. Sachin Pandov. It was very nice to see that. The next speaker, Professor Dr. Arun Bandasani sir, needs no introduction. He has been a teacher for hundreds and hundreds of endocrinologists who have been trained in PGI and then gone to all parts of country and even world for treating various patients of endocrine disorders. Sir is a researcher par excellence and a teacher, which everybody knows. So I'll just hand over the stage to sir for further deliberations. The sir's topic today is common errors in management of type 2 diabetes mellitus. Over to you, respected sir.
Thank you, Sachin, Rajat, and Dr. Dinesh. Thank you for very, very kind invitation and my tribute to Dr. Sachin Pandov for his untimely demise. So what I will be doing, I will be talking about the errors in management of type 2 diabetes. And this is in fact, it's a very thought-provoking talk, and it is in a very different style. It's in a question-answer format. What we usually talk about that and what we usually do, the errors in clinical practice in the management of type 2 diabetes. So we'll talk about what are the errors we make in diagnosis in fact. So see, what is the normal glucose profile? Say normal glucose profile is a fasting plasma glucose is less than 100. The 2-hour PG, that is a 2-hour post glucose. It's after 75 gram of anhydrous glucose load, it should be less than 140. And if you do a random plasma glucose at any time of the day, regardless of meal, it should be less than 140. And if you have a hemoglobin A1C cutoff as a less than 5.7%. So this is the normal glucose profile which the physician should be aware. There is no mention about the PP values here in a normal profile. So even if you do a PPG, it should be less than 140 in a normal subject, because the beta cell and glucose homeostasis is in very precise and tight regulation that does not allow the glucose to rise more than 140. As far as the diagnostic criteria for type 2 for diabetes, whether it is a type 1 or type 2, fasting is 126. The 2-hour PG, again it is a 75 gram anhydrous glucose, because the glucose which is available in our country, most of the time it is monohydrous glucose. So the weight will be 82.5 gram. However, now the anhydrous glucose is also available, but you have to verify what type of glucose have been used. So the 2-hour PG is 200, and random if it is more than 200, it has to be accompanied with symptoms. If the random glucose is more than 200 and not accompanied with symptoms, it loses its value in diagnosis. So that's a very important that while with the fasting and a 2-hour PG you do not require symptoms, but here the symptoms are also required along with the random plasma glucose, and the reason being because the random plasma glucose is influenced by your diet, your quantity, quality of meal and physical activity at any time of the day. So that's why the random plasma glucose, if it is accompanied with symptoms, then and then it makes a value, and a hemoglobin A1C of 6.5% should be confirmed on subsequent day. 50% of patients with diabetes, particularly type 2, are asymptomatic. So diagnostic criteria remains same, and at least you should have a 2 values as an abnormal, preferably one fasting and one random plasma glucose in presence of symptoms, or the 2 fasting glucose. Why the more stress is put on a fasting plasma glucose is mainly because the fasting plasma glucose in a given individual is almost consistent. And why it is almost consistent, or it has the least variability, because it depends upon hepatic glucose output, which is fairly constant in a given individual. That's why if you talk about the variability in a fasting plasma glucose, even in a same individual, is very, very low. It's very, very minimum, because the hepatic glucose output in a given individual is almost constant. A fasting sample should be obtained after overnight fast. It's 8 hours to 14 hours overnight fast is recommended. Remember that someone is coming in a OPD, say around 3 o'clock, and says, I am fasting since morning, I have not taken anything, it does not make it true fasting. Because the reason for that, because by that time your counter-regulatory hormones goes up and gives you fallacious values of fasting plasma glucose. The postprandial glucose does not figure out in diagnosis. If you see the diagnostic criteria, the PP glucose is nowhere. So it should be considered as a random plasma glucose for diagnosis, but for monitoring, we are doing as a PPC. A word about the pre-diabetes, because India houses now 8 crores people with diabetes and similar number of people with pre-diabetes. And the two terms we know all about, the IGT, everyone was aware, but the now IFG, which was introduced way back in 1997, where the fasting plasma glucose is between 100 to 125, or impaired glucose tolerance is between 140 to 199. Hemoglobin A1C between 5.7 to 6.4, as these values are in range, so the hemoglobin A1C is also in range. However, both have a similar connotations for progression to type 2 diabetes. Physicians should also be knowing about the sample which is used for assessment of a glucose is whether it is a venous plasma or whether it is a whole venous blood. The venous plasma means you take the sample into the oxalate vial along with the fluoride. While in a whole venous blood, the blood is taken not in an oxalate vial, but it is in a venous plasma, it is separated out. So the plasma is separated out. While in a whole venous blood, you take the whole blood as such. The venous plasma values are 10 to 15% higher. Why they are higher? Because the part of the RBCs into the whole venous blood, they consume some amount of the glucose. That's why the glucose is lower in a whole venous blood by 10 to 15%. And secondly, the part of the volume which you take for the assessment of the glucose in a pipette, it is also shared by the RBC mass. So that's also responsible for higher values in a venous plasma as opposed to whole venous blood. Capillary glucose is not recommended for diagnosis. However, now most of the glucometers are calibrated even for the venous plasma glucose, but it is more for epidemiological studies. Whenever you do for an individual, it should be done in a laboratory. Urine sugar has a no value in diagnosis, neither in monitoring. Hemoglobin A1C and diagnosis of type 2 diabetes, ADA criteria as I mentioned. However, remember that it has a low sensitivity and high specificity at defined cutoff of 6.5%. It is not useful in type 1 diabetes, hemoglobinopathies. So this is our data which we published way back in 2010, and you can see that at a cutoff of 6.5%, it has got a sensitivity of 65 and specificity of 88%. So even you miss 35% of an individual if you take a cutoff as a 6.5%. A GTT, just some precautions before you do a GTT. It should be done after an overnight fast, and the diet must contain at least 150 gram carb for 3 days. If someone restricts carbohydrate 3 days prior to the GTT, then the values are falsely elevated. And the reason for that, why the values are falsely elevated, even if you restrict the carbohydrate for 3 days, there is a remarkable improvement in a beta cell sensitive glucotoxicity that leads to decrease in response to glucose load on the day of the test. There is no alcohol in the preceding night, no exercise, morning walk, bed tea or smoking on the day of the test, and the 75 gram anhydrous glucose. And only 2 samples are recommended, 0 and 2 hour. You don't require a 0, 1 and 2, and neither you require the estimation of the urinary glucose as a part of the test. So it's a wastage of resources and money. For a GTT during pregnancy, you require the 100 gram glucose and 4 samples, but now most of the people after the HEPO study follow the IAD PSG criteria, where you use 75 gram glucose and you take 3 samples at 0, 1 and 2. Any single abnormal value, 92, 180 and 153 is labeled as GDM. Many times you find dubious values. Say fasting is 115 and random is 200 even with symptoms. So here the fasting is in a pre-diabetic range while the random is in a diabetic range. Or vice versa, fasting is 130, that is in a diabetic range, while random is 180, that is in a pre-diabetic range, that you see in clinical practice. Or you see a fasting is 120, that is in a pre-diabetic range, and hemoglobin A1C is in a diabetic range. So the recommendation is that you repeat the abnormal value on subsequent day. And suppose the abnormal value is the same, then it confirms, means it is concordant, it confirms. Suppose the abnormal value if you repeat, and again it comes in a pre-diabetic range, then the best is you do a GTT. So you can see that there are so many intricacies even in a diagnosis of type 2 diabetes. All cases are not so clear-cut, and many times you face these challenges. So remember that if any of these values is abnormal, the abnormal value should be repeated. Hyperglycemia during AMI and stress, any value more than 140 in indoor setting is considered as a hyperglycemia. You revise the diagnosis once the stress is over. And do not use the term mild diabetes or a severe diabetes. Avoid such terms to appease the patients. A word about the types of diabetes which are usually missed, the two diagnoses. The one is LADA and another is a Flatbush. If you clinically look and carefully look into the history of the patients, you can also easily make the diagnosis. However, FCPD is no more used. It has been termed as a pancreatogenous. IDDM is now type 1, NIDDM is type 2, or even you have a MODY. The what LADA is called as 1.5 diabetes, that is a latent autoimmune diabetes of adults. There are 7 characteristic features which you can just clinically pick up in your clinical practice. Age of onset more than 30, moderate or severely symptomatic, and these patients are usually sarcopenic. So they rapidly lose their weight. They lack the features of insulin resistance. Glucose values are quite high. They may not have a ketosis presentation. Usually there is no family history of diabetes, and the physicians has got a temptation to introduce with OADs to begin with, but they are GAD positive and the C-peptide is usually less than 0.6. So how do you pick up these patients? So any patients in an OPD who has come with a rapid weight loss, high glucose values, lack of family history of diabetes, best is you treat with insulin. You revise your diagnosis after 6 weeks or 8 weeks. Once the glucose profile becomes normal, you do a GAD antibody. If the GAD antibody is positive, then your diagnosis is LADA. Difference between type 1 and LADA is type 1 is an explosive presentation. It's a rapid destruction or immunoinflammatory destruction of beta cell, as opposed to LADA, where there is a smoldering immunoinflammatory destruction of beta cell. So the process of destruction of beta cell is faster in type 1, while it is tardy in LADA. The another entity, Flatbush, which is also commonly recognized now, and after the COVID we have seen so many patients with this type of presentation. The young age of onset, they are usually obese and insulin resistant. They usually present as diabetic ketoacidosis, so you usually label them as a type 1 diabetes. Beta cell function usually recovers after intensive insulin treatment, later may respond to OADs, and GAD antibody is negative. So any obese individuals who has got the features of insulin resistance, that we also see in clinical patients coming with a DK or DKA, and then recovers faster, and even later he may respond to even OHAs. These are the patients who are likely to have a Flatbush diabetes. Something on clinical examination which the physician usually misses. The height and weight are usually not taken. It helps in calculation of BMI, calorie calculations, and choice of therapy. The features of insulin resistance are usually ignored: acanthosis, skin tax, double chin, central obesity. The waistline is not measured. Many Indians, our patients are people with diabetes, are non-obese, but they are centrally obese. And it certainly better correlates with insulin resistance. The peripheral pulses are not palpated. The carotid bruit, if you find, it's a surrogate marker of CAD. Absent posterior tibial or dorsalis pedis, it's a surrogate marker of PVD, peripheral vascular disease. And if you find a renal bruit, there may be a renal artery stenosis. So you should be cautious in using ACE inhibitors, ARBs, because that can lead to acute renal insufficiency in these patients. Foot examination is usually ignored. Even our own data showed 8% of the patients with diabetes, they died of foot sepsis. Look for callosities, nails, pulses, arch, and it's one of the major causes of mortality, because now the people of the diabetes are living longer, And as you live longer, you are likely to have more complications. So foot or diabetic foot ulcer is a emerging problem. The hands are not examined. You may have a Dupuytren contracture, limited joint mobility, and trigger finger. The funda should also be examined. It's one of the important causes of diabetes as a painless loss of vision. So next question is, what is our target? The targets are usually confined to blood glucose, hemoglobin A1C, and recently more focus on glycemic variability. The focus on glycemic variability is of importance now because many patients, even with a hemoglobin A1C below 7, are developing the diabetic complications. So development of the diabetic complications despite the hemoglobin A1C in a target range suggests there may be a glycemic variability may be the cause. But the target should be not only for glucose profile, but target should be focused on all these parameters. So that's why we say it is a comprehensive control of diabetes rather than glucose control or glucose-centric approach. So this includes fasting between 80 to 130. The PPG should be less than 180. Hemoglobin A1C below 7 or 6.5 can be individualized. The target in range below more than 70. Blood pressure, I think 130 by 80 is most appropriate. LDL below 70, or if it is already say 80, then 50% fall from baseline. Known HDL, residual risk is 33%. Even you normalize LDL is less than 130, urinary albumin less than 30, and weight should be either 5 to 10% from baseline or ideal body weight. So the control of diabetes is comprehensive. So rather we should go from a glucocentric approach to the comprehensive control of diabetes. The next question, the physician has to identify who require tight control. So who should be on tight control? It is to be identified but to be individualized. Young diabetes without comorbidities. Now another set of the people in our country who are developing diabetes at an early age. So means between 30 to 40. So now the people are developing diabetes. So as you live longer, you're likely to have more complications. So young diabetes without comorbidities must be tightly controlled. GDM, post-transplant, and even patients with AMI and stroke try to maintain a glucose values between 140 to 180 as supported by the NICE sugar study. A word about the treatment strategies. I think now possibly the people would have revised the new ADA 2022 guidelines. I'll just tell what is the difference between last year and this year and what mistake we do in adding the treatment in these patients. A word about the lifestyle modifications. The aim is to lose around 5% of the weight, advised after evaluation for dyspnea on exertion, peripheral vascular disease, and obvious foot disease. Patients with a PDR, proliferative diabetic retinopathy, should be cautiously mentioned because they can have a worsening of the vitreous hemorrhage on a brisk walk. The usual we say 4 kilometers in 40 minutes, 5 days a week. And remember, the beneficial effect of insulin sensitivity lasts only for 24 hours. So suppose you say that I have walked already say 15 kilometers in 2 days and the rest 5 days I do a rest, then the beneficial effect of exercise is lost. So beneficial effect on insulin sensitive exercise is only for 24 hours. The current trend for a 10,000 steps a day, we don't have a robust data, but it shows that even if you walk 10,000 steps a day, you walk something around 6 kilometers a day. That's a good to maintain the weight or ideal body weight. Whenever the aim is to lose the weight, the exercise should be at stretch. If you do a short exercise trips like 15 minutes, you lose only carbohydrates. But if you want to lose fat, it should be at stretch. And a mixture of exercise is always recommended. You do isometric and isotonic. So a light gym, brisk walk, I think the combination of these exercises or push-ups, I think these are better than only alone brisk walk. The reason for that, with aging, you lose your muscle mass and there is an anabolic resistance. What do I mean by that? Even if you take an optimal amount of a protein, the proteins are not incorporated into your muscles. So this is called as anabolic resistance with aging. You can overcome by doing the isometric exercises by that. Now the whole approach have been changed from inertia to proactive. So that is now that the most of the guidelines now prefer sequential than combination therapy unless hemoglobin A1C is more than 9%. However, a trial, verified trial, we were the part of the verified trial, and combination therapy even at a lower hemoglobin A1C is recommended. Why we have dared to use the combination of the two drugs to begin with even at a low hemoglobin A1C, because the new class of the drugs like SGLT2 inhibitors and DPP4 inhibitors, they hardly cause hypoglycemia. Because one is because of the glucose dependent insulin secretion and one is because of absolutely insulin independent mechanism. So the risk of hypoglycemia is less, and that's why we are targeting even at a low hemoglobin A1C with the combination of the two drugs to begin with, and the verified trial was with vildagliptin and metformin. The failure with one drug within 3 months of optimal treatment require addition of next line therapy, and we should not hesitate to add insulin once the hemoglobin A1C is 9 or 10, 9 by ACE and 10 by AD at presentation, and you have already tried the 3 OHAs, preferably 1 sulfonylurea or 1 DPP4, SGLT2 and metformin, then best is you add basal insulin. Why the metformin as a first line drug? However, the new guidelines have they have slightly sidelined the metformin now, but I still prefer metformin as a first line drug because there is an effective reduction in hemoglobin A1C, it's weight neutral, minimal hypos, cardioprotective, promotes or potentiates GLP-1 action on beta cell, robust data from UKPDS, inexpensive. However, there is no randomized control trial for cardiovascular outcome. That's one of the, but it's a very time-tested, reliable, and virtually not associated with any undesirable adverse events. So it remains as a first-line drug. However, in the newer guidelines, it has been slightly sidelined this time, and more focus has been put on GLP-1 agonistic analogs and SGLT2 inhibitors. So this is the, now I think very clear, ASCVD used for SGLT2. If contraindicated, then best is use of GLP-1. Heart failure, SGLT2, CKD, SGLT2. So I think SGLT2 and metformin has now edge, and those who can afford GLP-1, then you prefer a GLP-1 with that scenario. And if you don't have any risk factor or no ASCVD or CKD, then your conventional regime. But I think the benefit of SGLT2 should be given to all. However, those who do not have a multiple risk factor for cardiovascular disease may not enjoy the same benefit in a prevention of cardio. But those who already got either risk factors or already established ASCVD, this is the only drug which can reduce the or which can prevent the mortality. So mortality benefit, so far we don't have any OHA except SGLT2 on a mortality benefit. So that's one of the major advantage of this class of drug. So add on metformin as a second line drug, either ASCVD, GLP-1 and SGLT2, CCF, SGLT2. For a cerebrovascular events, the pioglitazone was said to be the best. The reason for that, it has got a more effect on a CIMT, carotid intima medial thickness. For a CKD, use SGLT2 if the eGFR is more than 30. Now the newer data even with 20 are emerging, and DPP4 you can use lenine thanaligriptin even with the eGFR of less than 30. So I will just leave this, because why you should use a combination of a drug? Because you are targeting multiple defects. The glycemic durability and variability can be minimized. Early achievement of targets and evidence by verified trial. So this was the trial. I think I'll just tell you these two graphs. If you combine metformin plus vildagliptin together as opposed to metformin and placebo, then you see that there was a 50% of the people over the duration of 5 years failed to maintain their hemoglobin A1C below 7. So if you use a combination of a drug, even at a hemoglobin A1C of 7.5, you are able to sustain with hemoglobin A1C below 7 in almost all, as opposed to if you use a single drug, metformin alone, only 50% could maintain. So I think this is an instantaneous reduction in glucotoxicity. That's why you are able to sustain with your hemoglobin A1C of 7% or below 7% for at least 5 years. So that is the beauty of the verified trial, and that gives a rationale to use a combination therapy even at a lower hemoglobin A1C. The another question which is commonly asked by the patient in clinical practice is time of administration of drugs. The metformin should be ideally taken before 30 minutes prior to meal. That's an ideal time, because the metformin also potentiates the GLP-1 action, and metformin also has got an effect on gut microbiota. But if someone does not tolerate, you can give with meal. SGLT2 preferably in the morning, because they do cause diuresis. So using SGLT2 in the evening may be troublesome for the patient. The sulfonylurea should be used 30 minutes prior to meal. This is a data extrapolated from glipizide. The DPP-4 inhibitors 30 minutes prior to meal, because the first phase of insulin secretion occurs even in cephalic phase. So even you have seen the food and the insulin secretion starts, that is also partly mediated by GLP-1. Acarbose, as they are alpha glucosidase inhibitors, just before a major meal. The glitazones, ideally, because they do have a half-life or biological half-life of around 24 hours, but they do control postprandial hyperglycemia, they should be given preferably before meals. The regular insulin, what we are using sometimes 30 minutes prior to meal, because it's a hexameric, it has to be broken down into monomers. The short-acting analogs can be used just 5 minutes prior to meal, because they are already monomeric. And the long-acting analogs, however, they do have a flexibility of 4 to 6 hours. Preferably should be given at a fixed time. Otherwise, even they can also have a stacking effect. When to add insulin, I think I can leave this. So I'll just say errors in monitoring. So usually the physicians usually monitors fasting regularly. Most of the physicians, they do ask for that. It's easier in fact. But the PPGs, they do sometimes 1 hour, sometimes do 1.5 hours. The recommendation is 2 hours. Hemoglobin A1C at least should be done once in 3 months, but once it is below 6.5, it can be done once in 6 months. Blood pressure is not regularly monitored. Fundus is not annually examined, and foot is hardly seen. So you see that these are the guidelines and frequency. So fasting and PP for an intensive control, you require 4 to 7 point profile. If it is a conventional control, you can monitor slightly relaxed. Hemoglobin A1C once in 3 months, lipids once a year. If target not achieved, then 3 monthly. Microalburia, fundus and foot examination once a year. A word about lipids and diabetes. The targets is 30 to 50% reduction from baseline LDL. Now, people usually don't talk about the absolute values of the LDL cholesterol. Like previously, we used to talk 100, less than 70. The reason for that, 1/3 of the patients with diabetes, when they do have a cardiovascular events, their lipid profile is normal. So that's why now the targets have been modified to 30 to 50% reduction from baseline LDL. Dictum is all diabetic between the age group of 40 to 75 should be on statins. If they should be on high intensity, if there is a ASCVD, if there is a no multiple risk factors, or even without ASCVD, they should be on moderate intensity. High intensity means up to 40 milligram of Rojuva, or otherwise up to 80 milligram. Age between 20 to 39 years, it's a physician's choice, we don't have a data. Add ezetimibe or PCSK9 if the LDL targets are not achieved, and patients with diabetes and ASCVD. The time of administration of a statin preferably should be at bedtime, because the HMG coenzyme reductase activity is maximal at midnight. The triglycerides are still not targeted because the data are not so robust for the residual risk even after the normalization of LDL and non-HDL. But still, if the TGs are around more than 400, the risk of pancreatitis always remains. Best is you treat either with fibrates, your saraglitazone, and omega-3 fatty acids. A word about hypertension. What the physician does a mistake is that blood pressure is not monitored. It should be monitored in both sitting position and look for postural drop. The measure at each visit after 15 minutes of rest, and the target still 140 by 90. If there is diabetic kidney disease, 130 by 80. So this is the selection of antihypertensives. I'll repeat for you. The control of blood pressure in type 2 diabetes, diabetes is a state of resistant hypertension, like Cushing's, like acromegaly, like pheochromocytoma. So it's a state of resistant hypertension, and majority of patients require more than 3 drugs to control the blood pressure. If someone is hypertensive and there is no albuminuria, use ACE and ARBs. If normotensive micronuria, blood pressure is normal but there is a micronuria, use ARBs. If patient is hypertensive as well as urinary albumin, use ACE or ARBs and SGLT2. If person is macroproteinurics, then use ARBs and SGLT2, and now recently phenylalanine, mineralocorticoid receptor antagonist. Start 2 drugs if initial BP is more than 160/100. If blood pressure is uncontrolled, do not hesitate to use calcium channel blockers. If there is a proteinuria, then don't add the dihydropyridine derivative. Use the non-dihydropyridine derivatives. Use your hydrochlorothiazide or chlorthalidone to control the systolic blood pressure, and they do have a beneficial effect on CV mortality. Alpha blockers can also be used if the blood pressure is not controlled. The beta blockers, in fact, if there is associated coronary artery disease, they must be used. They should not be scared of that. They may cause hypoglycemia. So should not be scared of that. Use beta blockers, because in a patient with established ASCVD, only beta blockers can prevent the sudden death. That's why they should be used. Beta blockers, otherwise as an antihypertensive, they are poor and they causes weight. This is the only antihypertensive which causes weight gain, because they do have an effect on thermogenesis. So to conclude, the management of diabetes is now a state of art and has to be individualized. The diagnosis should be confidently acknowledged. As you looked into that, there are so many intricacies even in these numerical values. The clinical examination should be perfect. The choice of therapy is now tailor-made. For every individual, the set line of the drugs are very, very different. And associated comorbidities should be effectively addressed, because if you treat comorbidities effectively, you can lead to increased longevity free of complications. Thank you. Thank you for your patience.
Thank you, sir, for the wonderful and very informative talk. Any comments and questions are welcome.
No, I think there should be more questions.
Sir, do you go beyond 2 grams of metformin, so 2500, do you ever use?
Yeah. So if you ask about the recommended dose of metformin is 2 gram. And if you use say 2.5 or a 3 gram, it does not translate into the glycemic benefits. So the reduction in glucose beyond 2 gram is not statistically significant. That's why up to 2 gram is fine.
Sir, in your practice, on an everyday basis, do you treat pre-diabetes with pharmacotherapy?
So reason for that, for a pre-diabetes, I think first 3 months I always try them go for a lifestyle modification program. But many people, they do that, but they are not able to sustain with it. So I think the best is I treat with metformin, and now I even treat with DAPA and metformin combination. Because now we have a data of a DPP, Diabetes Prevention Program, 15 years data. So even in a 66% of individuals, diabetes could be prevented. So they still remain. You have 3 options in a pre-diabetes. Either you become diabetic, you stay pre-diabetic, or you revert to normal. So 66% either reverted to normal or remained pre-diabetic. So if you can prevent diabetes even for a 15 years by using say 1 to 1.5 gram of metformin, I think it is a better choice than believing on the sustainability of the lifestyle modification program.
Because many a times the lifestyle modification just flitters after 3-4 months and
Exactly.
patients go back to the same thing.
It is difficult to sustain forever. Okay, so if they become normal, then the clue for that, you can dare to stop the medications in that scenario if they really have a weight loss. So suppose someone is a pre-diabetic, you are treated with a lifestyle modification, and even you have used metformin, and if they lost even a 5% of a weight loss, then I think you can dare and you can watch. But if someone has not lost weight, the best is continue. So So I think I will stop DAPA first, followed by metformin, because the metformin data are very, very strong. And DPPs over the 15 years data, yes, 15 years data are more robust. And for DAPA, we don't have such data.
So nowadays we have a new trend in terms of lots of people getting diagnosed almost at an asymptomatic stage with not pre-diabetes but diabetic, mildly elevated A1C, and coming to us but saying ki treat me naturally. Treat me naturally. Driven partly by the noise in social media and so many stuff. So that's a very tricky situation, which is almost every day we are getting one new patient like that.
So treat me naturally means more on lifestyle modification. I believe that only. So I think that we always stress, we always say that, but I think you give a time of 3 months. 3 months is a reasonably good time, or 6 months is a reasonably good time if they remain in follow-up. And if they really follow, it helps. Because many patients, like I will just share with that, the many young type 2 diabetes which we have seen, and even they were presented at diagnosis as a hemoglobin A1C around 10 plus. Initially aggressively treated with insulin, and then stopped insulin say after 2 months or 3 months, and now their hemoglobin A1C is even 5.3. But they have lost 7 kg weight during this period. So today, even I dare to stop everything. And let us see that, because the remission of diabetes, the definition is that maintain hemoglobin A1C below 6.5 after the stoppage of drug for more than 3 months. So we'll just see that. And the reversal is now no more people are using, because reversal gives you a false hope. So it's basically, it's not a cure. So we say it's a remission of disease. In a remission, there is always a scope to recur again. In a reversal, you are giving a false hope of getting it cured. So that's the difference between remission and reversal.
Good evening, sir. It was a wonderful talk. I just want to ask, what is your comment when there is new onset diabetes after renal transplant? So, new onset diabetes after renal transplant, SGLT2 inhibitors still we prefer as first line, or there is something else?
No, yes, why we should not prefer an SGLT2? SGLT2 inhibitors and a metformin should be a good choice. And if their hemoglobin A1C is, say, above the targets and you are not able to achieve, even I would like to give a basal insulin. So I think because in a kidney already, which is a transplanted kidney, it's a very precious kidney. So treat aggressively and maintain a hemoglobin A1C of below 6.5. So I will prefer to use SGLT2 inhibitors as well as the metformin together. Thank you.
Thank you very much, respected sir.
Thank you, sir. I request the chairpersons to present memento to Dr. Anil Bhansali. I request Dr. Rameshwar Gupta to present the mementos to the chairpersons. Dr. Rajat Gupta, Dr. Sachin Mittal, Dr. Dinesh Garg. Moving ahead with the panel discussion, early detection of comorbiditis in diabetes mellitus, recent guidelines-based approach. I request the panelists to be on dais. Dr. Subhash Verma, MBBS MD, Internal Medicine from Fortis. Dr. S.K. Mathur, MBBS MD, DM, Endocrinology from Max. Dr. Puneet Verma, MBBS MD, DNB, DM, Cardiology from ACE Heart Center. And Dr. Manish Chauhan, MBBS MD, DM, Nephrology from Max. The moderator of this panel discussion is Dr. J.K. Mokta. I request the panelists to address the moderator. Thank you.
Hello, check one.
Hello. Good evening, sir. So today we will going for now the question answer for this today's talk, and I have framed 6 questions. I think it is as per the 2022 ADA AS and ADA EST guidelines together. The answer will be based on the latest guidelines base, and it is the question I have framed is based on the daily OPD the patient presents to us. The first question goes to Dr. Verma. So here, sir, here is a 39-year-old who visits to see you because of his abnormal glucose value while he underwent his routine annual checkup. His fasting plasma glucose 190, postprandial glucose is 149. He is apprehensive he is suffering from diabetes as his father is having type 2 diabetes. So how will we proceed? What is the next step we plan as per latest ADA 2020 guidelines?
So I think Dr. Bansali alluded to what is being done as of now. So the fasting is within a range here. Postprandial is more than 140, but then you would actually need a 2-hour, either you do a GTT at 2 hours and you do a hemoglobin A1C here.
Okay. Sir, you ordered a OGTT and his BMI is 24.5, his blood pressure is 136/86. And his next visit, he present with A1C of 6.3, 2-hour post glucose value are 179. His total cholesterol is 224. His TG is 201. HDL is 33. LDL is 137 milligram. So what is the next step that we should treat, and should we treat for him for, and what treatment you will offer to this patient?
So Anil again alluded to that particular thing. I would say that lifestyle modification and weight loss would be the first thing to do in this patient, and then follow this patient at 3 months.
Sir, the question is that it is the weight, when you should prefer to add the anti-diabetic drug, or that has been shown metformin, pioglitazone, SGLT2, what is the time that you should add? That audience wants to know that.
So from your data, actually, I mean, you are saying that hemoglobin A1C is 6.3, right? You are also saying that the sugar values, 2-hour sugar is 100 and?
Postprandial 2-hour is 179.
So I think the first thing would be to go for lifestyle modification here, wait for 3 months and then see what happens.
Okay. His blood pressure is 136/86 and his LDL is 137. What is the latest ADA recommend for the cardiovascular risk in pre-diabetes patient?
Okay, so when I say lifestyle modification, they would also include about, they would also talk about controlling the comorbidities. And here, if, and as Dr. Bansali was saying that you have a higher LDL, you would like to bring it down by 30 to 50%. So you can start this patient on lipid lowering agents. Triglyceride, I'm not very sure whether you would like to do anything at this stage.
So any comments from other panelists, any suggestion or anything else that we can do in this patient? No. So second question go to Dr. S.K. Mathur.
Yeah.
Sir, here is a 52-year-old woman from rural background of Himachal Pradesh who presents to outdoor clinic with fasting plasma glucose of 170, postprandial glucose of 279, HbA1c 8.9. How should she be treated in the outdoor setting as per the latest ADA-ACE guidelines?
So is she drug naive or is she taking?
Yeah, first time.
First time, okay. So I think this is a good case wherein we can, A1C is 8.9. So I think we should start with lifestyle and then we have to, at the same time, because the A1C is 8.9, I would like to start her on metformin and combination of metformin and DEEP4 inhibitor. If her BMI, I'm not knowing about her BMI. Or
Okay,
even
so her BMI is 26.
26, then a combo of SGLT with metformin could be a good choice.
Her BP is 136/88, uric acid is 25/07, ACR is 19 milligram per gram, and his LDL is 109.
It's fine. I think we should give her a dietary modification. We should reduce her LDL unless she has a family history of CVD, or because right now as the profile which you're saying doesn't show that she's at a high CV risk, although she has diabetes, but she doesn't have any other evidence to show that she's having a cardiovascular disease. So, and she's 52, so maybe, and LDL is 106 or something.
109.
109. So we
will not
want it to be 100, yeah, that's all.
Okay, and blood pressure 136/88.
Yeah, so we give her a low salt diet, ask her to reduce weight, which should cure her BP if she follows it.
So the ACE guidelines says the BP of more than 136 or American College of Cardiology and any other cardiology in diabetic patient and any patient of chronic kidney disease, if BP is more than 130/80 should be treated. What is your opinion regarding that?
No, definitely BP of 130/85 is the ideal for this patient.
Yeah, what is your opinion? You should treat or we should treat or not? The
No, I
question is
think
being asked.
because it's, if we just go for numbers, so I think we can give her a lifestyle option.
The target BP actually in CKD would be, a patient with diabetes and CKD would be 130/80.
Yeah, I'm not talking on CKDs. The uric acid is normal, ACR normal. What the ACE guidelines and American College of Cardiology, if BP is more than 130/80 in diabetic patients should be treated. What is your concern about that? Because this is a question the audience want to know.
See, there is no role of giving a preventive dose of ACE or ARB.
Question is not such preventive. It is the ACA guidelines and it is the AD. I'm not talking of myself.
Yeah.
They say BP more than 130/80 should be treated. What is your concern over that?
130/80 on a casual visit, I think it's too early.
And LDL 109. Should we treat it or not?
No, I don't think.
Okay.
Pharmacological
Because
therapy
the AD
also.
guideline, AC guideline definitely tell us, in ACE guidelines, say we calculate the atherosclerotic cardiovascular risk. If it's more than 10, high statin should be used. Yes. And according to ADA, if more than 40 years of age, one risk factor should be treated with year and bring it less than 100. That is the guideline. I'm talking of the guideline. I'm not talking of any ifs and buts. It's the guideline that is recommended in 2022. So third question goes to Dr. Puneet Verma. Sir, this is a question from ADA 2022. I was listening the guideline who has written it. He have put this question in the discussion part, sir. I have taken it. Mr. Singh, who is 45-year-old, comes to see you because he checked his blood glucose with mother's glucometer and his morning levels were constantly above 200. His A1C was 9.1. But on asking, because the first question when we ask is the comorbid condition. The first question on asking, he told he had coronary disease 3 years back, and he's taking ecosprin, and he's taking lisinopril, and he's taking statin. His BMI is 36. So as per the 2020 ADA and ASC guidelines, what is your management in this patient for anti-diabetic?
Good evening. He should be treated actually on all fronts. I mean, there is little doubt that he is a diabetic. He's got coronary disease. Ecosprin, maybe if he's using a combination, we must know his cholesterol lipid profile. The complete lipid profile should be known. What kind of coronary artery disease is he having? Whether it's is it medically under GDMT, guideline treated medical therapies or not? I don't see any beta blockers in him. Especially, he is on ACE inhibitors.
Yeah, you think the
statins
person
have
after
to be
having 3 years of the acute coronary syndrome should be on beta blocker?
Sorry.
A person having coronary artery disease after 3 years should be on beta blocker,
After,
as per the guidelines.
Well, I mean, he has history of CAD. We don't know whether it's what kind of CAD. Is it now stable, symptomatic, chronic stable angina, or what is it? We are not talking about an acute setting, but certainly with an A1C of 9.1. We have to be more, we have to be aggressive on all fronts, frankly, whether it's the controlling all the atherosclerotic risk factors in him associated with the coronary artery disease, which includes diabetes, hypertension, dyslipidemia. So, and his BMI, it's horrendously, he is obese. So
A1C is 9.1.
A1C is 9.1. So obviously it merits.
And that is my question is, what is the treatment option this patient suits as per the 2022 guidelines?
No, treatment of what? Diabetes?
Diabetic. I'm talking about
diabetes. In this, it's quite clear that he has to be started on treatment at least within SGLT2 and a metformin. These two are compulsory drugs for him. And, and based on whether we consider him suitable for a GLP-1 analog.
He is businessman and his annual income is about 10 lakh per year.
Well, I'm sure he can afford a GLP-1 analog.
So what are the latest guidelines tell you? What's the latest guideline?
We said so that the first option should be with the GLP-1 analog.
Okay. You put him the GLP, he comes after 2 months, and his A1C is 7.7. And his echo ejection fraction is 58, and N-terminal BNP is 100 nanogram per deciliter.
And
his BNP is 100 nanogram per deciliter, and his echo ejection fraction is 58.
Okay.
So he comes, you put him on GLP, and he comes back after 2 months, and his A1C is 7.7. What's the next step you will do?
Consider using an SGLT2 inhibitors if he is tolerant to it.
So latest guidelines is that we should use GLP or SGLT. If not control the combination before adding the metformin is the crux in this patient. That is the latest guidelines. That is evidence. Okay, now the question is question number 4. Munish Chauhan, Dr. Munish Chauhan. Here is a 63-year-old female suffering from type 2 diabetes for last 15 years. Visits on an outdoor clinic on 1st November, real patient, 22 for her routine, 3-month routine checkup. For diabetes, she was taking metformin 1000 milligram BD, 10 gliptin 20 milligram. For hypertension, she was on amlodipine 10 milligram. On evaluation, her BP is 128/78, BMI is 23, A1C is 8.1, fasting plasma glucose 156, postprandial 220, ACR urea creatinine is 30/1.1. and EGFR is 76 per minute. TC is 129, triglyceride is 150, LDL is 100/01. How should another diabetic drug be added to her present regime and send her home, or should she be evaluated further? Your comments on that?
I think now the 63-year-old female, she is diabetic for the last 15 years.
Yeah.
And her HbA1c is 8.1.
Yeah.
So she needs better control of blood sugar, because maybe the diabetic nephropathy is setting in with an ACR of 30. So Definitely HbA1c should be achieved somewhere around maybe less than 8 is okay, but it should be around 7, I think. 7 HbA1c should be achieved, and definitely another anti-diabetic drug should be added to our present regime.
Which drug?
If one can confirm anti-diabetic drug, one can increase the metformin dose, or but one can add the SGLT2 inhibitor also in this patient.
Sir, here it is a clue that then according to 2022, because if you see all of the investigation given here, uric acid is given, but there's no ACR report given to this patient. So I sent her back. Fortunately, I sent her back for, because her uric acid is within normal range, I sent her back for ACR, and fortunate enough, her ACR was 1.8 gram per gram of crats. And when I went to a literature, Fidelio trial, they have noticed 40% of the patient has proteinuria without having raised ESR. So she comes out with the ACR of 1.8 gram per. So anything you want to change in patient now?
Yes, why not? If there is obviously proteinuria is heavy, then ACE inhibitor and ARB should be added to this patient.
And sir, I mean,
yes.
One thing that, what else?
Then SGLT inhibitors, SGLT2 inhibitors.
SGLT2 should be on that. What else?
We should try to increase the dose of ACE or ARB to the maximum dose tolerated. And
how about the statin?
Statin for this patient, the LDL is 100. There is no any cardiovascular. If she is diagnosed, her GFR is normal, ACR is 30. So if she is diagnosed to have diabetic kidney disease, then yes, you can.
She's not, according to 1.8.
No,
she's not.
1.8 she is, but the value which is given in this
so,
is
but
30.
It has been seen that it is not only the urea creatinine. Urea creatinine is close to your dialysis, but if your gut ACR increased, then it is
yes. Diabetic nephropathy you can diagose by either proteinuria or GFR.
So
yes.
statin high, there's statin.
So statin can be increased in, yes, can be added in this patient, and we can achieve the LDL of 70 also. In
70,
this
yeah. And how about your non-steroidal MRA now? It is
non-steroidal MRA, they have shown to reduce proteinuria.
Should be added, definitely,
they
because
can be added, but I don't know what is the
Fidelio trial, it is the proteinuria that was only present in 40% added, reduced the progression of
firstly,
kidney disease.
you go step by step. You initially you use ACE or ARB and go to the maximum tolerated dose, and then see how the proteinuria decreases, and then you should try to add another drug and then another drug. It's not in a one go that you add ACE, ARB and
now
MRA
one
and
question
everything.
that I just want to know is your aspirin. Should the aspirin be added or not? What is the concern of primary prevention of the aspirin therapy of day?
I can't say that this patient requires aspirin.
So aspirin, today's concern of 2022 guidelines is if atherosclerotic cardiovascular is more than 20%, definitely it should be added. But the age should not be more than 70. And if it is between 10 to 20, in the presence of the risk factor like proteinuria, retinopathy, or more than 2 traditional risk factors, you can discuss with the patient and add it. But it should not vary in more than 70 year of the age. So Dr. Baumas, here is a 65-year-old male suffering from type 2 diabetes for more than 10 years, present with a complaint of breathlessness during his routine work for quite some time. For diabetes, he is on metformin 500 mg BD, sitagliptin 100 mg BD, and his BMI is 28 and weight is 72. How we should proceed in this patient?
So I think I will not talk about the guidelines here. I'll talk about a common sense approach that you would have to a patient like this. So when you have shortness of breath, the reasons could be either in the blood or in the lungs or in the cardiovascular system. So you first examine this patient. This patient has been on metformin for a long time. So you look at whether or not this patient is having low hemoglobin. I've seen people undergoing angiography when they were on metformin and they had low hemoglobin.
Complete hemoglobin is normal value.
Okay, so if it is normal, it's okay.
Okay.
But one of the things that we must realize is that metformin reduces B12 levels, can cause megaloblastic anemia, and can cause fairly severe anemia, which could be symptomatic. So the first thing would be to look at the hemoglobin values. The second would be to look for a cardiovascular disease in this particular patient, and cardiovascular disease occurs because of a variety of reasons. They have an increased tendency for coronary artery disease, atherosclerosis. they can have heart failure that is induced by diabetes of long-standing duration. They can also have other associated conditions, like if there is a chronic kidney disease that is occurring in
So
these
you
individuals.
I examined the patient in the OPD, the JVP was raised and he had bilateral pitting edema.
So, you know, if the JVP is elevated and there is a bilateral pitting edema, then you are talking of congestive cardiac failure or a fluid overload. So I do not know what is the renal status in this particular patient.
Urea rates in this patient, his EGFR was 50 ml per minute and ACR was 100 milligram per gram of the urine.
So again, you know, which means that it is a combination of CKD plus maybe heart failure in this patient.
Sorry, his echo was done, ejection fraction was 15%.
Pro-BNP.
And was 4000 picogram per ml.
So when you have a pro-BNP at this level, you would say that this patient is having congestive cardiac failure. This might be contributed to some extent by the kidney disease, but it's predominantly cardiac to my mind. So you've done an echo, you said that there is a slightly reduced ejection fraction, right? MR.
15.
15.
15.
Well, then you would say that this patient is having cardiomyopathy-like picture, right? And you need to treat as you would treat any congestive cardiac failure, decongest this patient.
With the
So this patient would require a combination of things, including diuretics. Problem with ACE inhibitors is likely to be there because the renal functions.
So what is the time that you will add SGLT2? That's the question the audience want to add.
What is the time?
Time SGLT2 be initiated in this patient.
SGLT?
SGLT2.
Yeah, so I think they are now, I mean, you've had a talk on SGLT2 and that there's a clear indication of using these agents in patients with cardiac disease, and they are the only ones that would most likely make an improvement.
So it should be with combination of this diuretics, or you wait for the decongestion then add the SGLT2.
No. So there is a clear indication for using diuretic here. This patient is fluid overloaded. So you can't wait SGLT to work on this particular thing and then use diuretics. So there is a clear indication of using diuretics and also use SGLT2.
Combined together. That is the question. That's the question. Now the last question goes to Dr. S.K. Mathur. Sir, he is a 51-year-old male having diabetes for last 13 years, present to you for routine checkup. His medication include metformin 2 gram, Glimi 3 milligram, Sita 100 milligram. For hypertension, he is taking amlodipine 5 milligram. On examination, BMI 25, blood pressure is 134/84. On asking from patient, he is not suffering from any atherosclerotic cardiovascular disease, heart failure with reduced ejection fraction, diabetic kidney disease. He is smoker. His fasting is 140, BP is 209, his A1C is 7.7, LDL is 29. So what next in this patient?
So if he's not having anything, any ASCVD, any heart failure, any diabetic kidney disease, and he's only having an uncontrolled diabetes for past 13 years. So I think definitely we can add on a SGLT2 inhibitor or a GLP analog to bring down his A1C, and we can investigate for presence of diabetic kidney disease.
Yes, okay, sir. Now I asked the patient for the laboratory test of the kidney disease. When he came back after 2 days, his urea was 33, creatinine was 1.13, his ACR was 653 per gram.
Okay.
And his ejection fraction was 57, BNP was 440 picogram per deciliter. And this is a real patient who came to me from Kullu. And when I went for background retinopathy, that is not being done. She has mild background retinopathy. And when I went for the fifth score, it was 2.22. That is the patient we see usually in OPD.
What was 2.2?
Fifth score for cirrhosis.
Okay.
Fifth force code, that AC is.
Okay.
So how will manage
Okay.
this patient now?
So I think best choice in this case would be SGLT2 inhibitor.
Okay, SGLT2.
Because it improves liver fibrosis.
So what do you think, what is the risk of the patient for atherosclerotic cardiovascular? He does not have, what is the risk in your patient? Sitting in OPD, how can we calculate the risk of the atherosclerotic cardiovascular with all these parameters?
Yeah.
That is the question.
By
I think
sitting
that-
in OPD
Yeah.
without any other
Yeah,
investigation.
yeah. These are investigations we have got.
Okay. So what we can do is that we can look for even if we suspect a cardiovascular disease.
He does not have.
He does not have, he says this. But we should look for peripheral pulses.
Okay.
We should look for a carotid brew.
Okay.
We should look for his BP is already.
Yeah, 134 by 88.
So he's already hypertensive.
So the latest guidelines say we should look for the risk profile in a patient for long-standing diabetes. 4 things: duration more than 10 years, diabetes age more than 50 years, target organ damage, proteinuria, retinopathy, and LVH. If these are present in a person, should be very high risk equivalent to your atherosclerotic cardiovascular disease, managed according to very high statin with SGLT2 and GLP. If our have got a traditional factor with diabetes more than 10 years, with more than 50 years, he should be considered high risk. That is the question that I want to say. Ki the high risk and very high risk based on what we can do everywhere in nook and corner of the, and we can manage the patient according to prevent the development of atherosclerotic and heart failure.
I would like to make a point here, since we have a cardiologist amongst us. See, there is no risk engine which has been developed typically for Indian patients. If you talk of all the other risk engines, none of the Indian patients were part of it. So I think it's high time we should develop our own risk engine. Because every Indian patient cannot be compared to a Caucasian patient. We behave quite differently to assess cardiovascular risk. I think it's a good time we should have our own parameters.
Thank you. Thank you, sir, for your kind attention and expert opinion. Highly thankful and grateful, sir. Thank you very much. Thank you, audience.
Thank you, sir. I request the panelists to present mementos to Dr. J.K. Mokta. Thank you. I request Dr. N.P. Singh to present the mementos to the panelists. Dr. Subhash Verma. Dr. S.K. Mathur. Dr. Puneet Verma. Dr. Manish Chauhan. Thank you all for being with us today. Now I request Dr. Gyaneshwar Myani to conclude the session and deliver thanks speech.
मुझे लगता है हम सब पहले ही बहुत लेट हो गए थैंक्स की जरूरत नहीं है आई रियली थैंक एवरीबॉडी आई थिंक सो वी हैड अ वंडरफुल faculty, wonderful delegates, and support of the pharma company. And I really thank everybody for coming and honoring us. This is from our team, Tricity Dr. Forum.